Well, welcome. It's 6:22 p.m. in Tanzania, but I'm wide awake and eager to share with you a little bit about what our journey has been in the realm of tackling the big problem of newborn diseases and death in East Africa. Most people, when they think about babies and children dying, they consider the obvious diseases such as malaria, HIV, pneumonia, diarrhea, even tuberculosis. But those are all relatively small contributors to childhood mortality now compared to the big looming problem, which is newborn diseases, particularly prematurity. The WHO says that prematurity is the global cause of death in Tanzania. Babies are born premature at 3 times the rate as in Europe. And so how does a low resource country tackle the problem of neonatal deaths, particularly from preterm babies, but also sepsis and birth asphyxia? We'll share a little bit of our journey and how we did it. And as a result of our work in northern Tanzania, we have become the most recognized hospital in Tanzania for our ability to care for these babies. We'll share with you the simple steps that we took and what we're doing to try to expand low-tech, high-effective means of taking care of these sick babies in a country like Tanzania.
So Steve, I am going to invite you also to share just a moment of further words about yourself, if you would. We were just asking, although we've got it all here, I'm going to let you say your own words a little bit, if you can, maybe 30 seconds about your training and background, which would be delightful. And I will let you continue with the presentation as soon as you're ready. We are ready technically, and I'm going to step over here and be your technician too.
Well, I'm looking at a picture of myself. So this is kind of like talking to yourself in a mirror, which I suppose that's okay. My wife says I do talk a lot. And sometimes I'm talking to myself because everyone else has stopped listening. So nothing's really different today in our time together. But right now, what I'm seeing on my monitor is just a live image of myself. So I am a missionary kid. My parents were Lutheran missionaries in Taiwan for over 30 years. My father was a seminary professor and a writer, and they lived in Taiwan and then Malaysia from the early 60s to the early 90s. My father's older sister was a missionary in Tanzania for 40 years. So in both sides of the family, there was definitely missions that were involved. And having grown up as a missionary child, I always had a love for being overseas, and I wanted to give my kids a similar international experience. However, I had to get through university first. I had to get through medical school. I had to find a life partner who was as passionate about international work as I was, which I am grateful that I did. We had to start our family. I had to pay off medical school bills. I had to build a career. I had to do a fellowship in pediatrics and then another fellowship in pediatric infectious disease and then another fellowship in epidemiology and public health through the CDC. And then I worked at Hennepin County Medical Center for 8 years as the inpatient medical director for pediatrics and on faculty at the University of Minnesota. And in my late 40s, I came out to do a short-term trip in Tanzania, and Mark Jacobson, who had been a 40-year missionary to East Africa, particularly Arusha, kind of got his hook on Jody and I, convinced us as people who are looking for a long-term international assignment that Arusha and Arusha Lutheran Medical Center, Celian Hospital would be just the place for us. And lo and behold, we moved out here, and that was in 2013. I still am on faculty at the University of Minnesota in the Global Pediatric Program. I am sponsored as an ELCA missionary, along with Steve and Bethany Freeberg, who I heard Doug mention earlier. When we came out to Tanzania, we had a 7-year-old, a 10-year-old, and a 13-year-old. And the 13-year-old didn't necessarily want to come to Tanzania. She was in 7th grade in Linden Hills at the elementary school there. How many 7th graders are willing to up and move to Africa and leave all their friends behind? But she did. She fell in love with Africa, as did my other 2 kids. And Hannah is now starting her junior year at St. Olaf College and interested in veterinary medicine and conservation work. My son is now at UW Madison in his first year of university. And then I have a daughter who's 16 and she's at boarding school at Rift Valley Academy. So Jody and I are starting our 10th year now in Tanzania, and it has been, our next year will be our 10th year. It has been a remarkable journey, harder than we ever imagined, but also more rewarding than we could have ever hoped for. And that's my short introduction. Doug, when you're ready, we'll get on the first slide.
That is fantastic. Awesome. I'm so glad that you took time to share with us. I think, judging from the faces around here, we are warmed, and you can't see it, but we are warmed by knowing you a little bit more personally, even before we look at this. But I am going to, we're all able to see your presentation at this time.
Okay. So I really want to take you through really a story of how we help critically ill newborns survive in Tanzania. And we can extrapolate this to any really low and middle income country. There are 3 basic steps. They're not easy steps, but they're basic steps in helping babies survive. So Doug, if we could have the next slide. Our learning objectives are actually going to be really to understand the changing epidemiology of early childhood mortality in Africa as communicable diseases decline. When I became a pediatrician, I wanted to tackle the problem of communicable diseases. By that, I meant malaria, tuberculosis, pneumonias, bacterial infections, parasitic infections, because these diseases, which are transferred from person to person, were the leading causes of death for children. And that was true up until about a decade ago. But now that has changed. And though these diseases of historic interest are still important, they are not the burden of disease that newborn diseases is. Next, Doug. We also want to identify what the obstacles in establishing neonatology services in a low-resource country such as Tanzania is. We can say, for example, that, okay, there's a problem of prematurity, problem of babies dying, but it's not that easy to develop a capacity for a hospital to care for them. And along those lines, what are the 3 basic steps that all hospitals have to implement in order to save a preterm baby in their neonatal intensive care unit, otherwise known as the NICU? Next. So I don't have any financial relationships to disclose, and standard disclosure before we give a medical talk is that I won't be discussing any investigational drugs or off-label use of medicines. Next, the pictures that we're going to use for babies and mothers are always obtained with the full approval of the caregiver. So we make a point to, when we take a photo of a baby, to ask the family if they're okay that we use this for education, for fundraising, for training of doctors. And to date, I've never had a family say no. So Arusha Lutheran Medical Center, our NICU, if you walk into it, it looks quite nice by most African hospital standards. Yes, there's hospitals in South Africa and in major cities like Nairobi that perhaps are a bit shinier, newer, or have better equipment. But by Tanzanian standards, our NICU is actually quite remarkably nice, well laid out, and with a fair amount of working equipment. However, next, that was not the case in 2014. In 2014, our NICU, when I arrived in 2013, was crowded. It was chaotic. We had a single room, which could have up to 15 babies in it. There was a lot of equipment crammed in, but over half of it was not working properly. Next. And if you look around in the room, next slide. If you look around in the room, you will note that in these photos, there's not a nurse or a doctor present in these rooms. So they were crowded, the equipment was broken, and there weren't nurses or doctors that were present. Next slide. If you look at the causes of NICU admissions, they're for prematurity. They're for babies turning yellow, what we call jaundice, newborn sepsis, birth asphyxia, breathing problems. Some babies come in with severe dehydration, having lost 20% of their birth weight. Babies can have congenital anomalies or be born with surgical conditions. These are just a few of the reasons that babies would be admitted in our hospital or any hospital following birth. Next. And oftentimes we had babies that would lay on a table, 2 or 3 on a single warming table, because we just didn't have space due to crowding. Next. In the early days of our NICU, we didn't really know what we were doing. We tried to modify ways to help babies breathe, such as on the photo on the left. We had babies laying under the warming tables for far too long, and that was not ideal either. And if we go to the next slide, if you look at our growth in our NICU, you can see that in 2012, we had 59 babies admitted. In 2013, we had 117. By 2014, we were doubling every year. But the sad thing is, look at the deaths, 53 out of 222. And if you could do the next, that was a mortality rate of about 25%. So put differently, 1 out of every 4 babies that were going to come into our unit were never going to leave. They would pass away. And next slide. And furthermore, in 2014, our extremely low birth weight babies, which would be called ELBW, these are babies that weigh less than 1,000 grams or 2.2 pounds at birth. Our survival rate was only 20%. So if we had a baby that was born under 2.2 pounds, they had a 20% chance at surviving. 80% of them did not. Those numbers in 2014, as bad as they sound, were and still are better than what most government hospitals have today. Let's go to the next slide. There are findings that are published every 3 to 4 years in the Lancet by what is called the Institute for Health Metrics and Evaluation. This is an organization that actually funded by the Gates Foundation through University of Washington that looks at the burden of disease. Next. If you look at the global burden of deaths in 2019, looking at both sexes, all ages, ischemic heart disease, as you can see, is about 16% of deaths. So 16% of people who are globally going to die of heart attacks or ischemic heart disease. Another 12% is due to strokes. Another 4% is due to lower respiratory infections. And 3% of all deaths are in the neonatal period. So 3% of global deaths are in the newborn period. However, let's look at Tanzania, not global, but just Tanzania. And you can see that 11% of all deaths occur in Tanzania. And this is actually significantly higher than any other cause of death in Tanzania. About 9% of deaths are from lower respiratory infections or pneumonia. And about 8% of Tanzanian deaths in 2019 were due to HIV. This is all ages. So it's not ischemic heart disease. It's not strokes or cancer or car accidents in Tanzania that are killing people. It's in the newborn period. And furthermore, if you go to kids under 5 years of age, it's a third of all deaths occurring in children less than 5 are in the newborn period. And this is not including congenital anomalies. Pneumonia, on the other hand, is only about 14% of deaths in kids under age 5. And malaria is about 11%. And that number of malaria is dropping rapidly in Tanzania. HIV is less than 1% of all deaths under 5. So if we go to the next slide, and you look at neonatal diseases, we can ask the question, well, how many deaths per year are occurring in Tanzania? And the truth is, we don't really know. Because babies less than 28 weeks are generally not considered live births in this country. In Tanzania, today, if you're a premature baby and you're less than 28 weeks, you are not considered in government statistics as a live birth. They count you as an abortion or a stillbirth. Furthermore, a lot of live births may not be reported to the government, especially those that are occurring in villages or home deliveries. And death registries are incomplete or inaccurate. Even in hospitals today in Tanzania, many babies will die and they will not be reported as a death. They will simply be written down as a stillbirth or a miscarriage. So the rates of prematurity in Tanzania are higher than global averages. Globally, rates of prematurity are somewhere around 8 to 9%. In Japan and Sweden, they're under 6%. But in Tanzania, they're up to 17%. And somebody would ask me, well, why are so many babies in Tanzania being born premature? And there are really basically 3 reasons for that. Number one, mothers are not getting good prenatal health care, so their diseases are not managed well during their pregnancy. Number two, there are a lot of young mothers giving birth, and the younger you are, the more likely you are to have a preterm baby. And number 3, if maternal nutrition is not good in the country, if mothers are malnourished during their pregnancy, they're more likely to have a premature birth. For these reasons, babies in Tanzania are more likely to be born premature than just about anywhere in Europe, North or South America, or Asia. Next. And so one of our difficulties is trying to educate doctors that premature infants are not the same as normal babies. Just as children are not the same as small adults, so also preemies are not just small babies. They have unique needs in their initial resuscitation. They have specific risks and unique hospital care needs. In addition, a premature infant has a very unique nutritional demand. They demand far more calories, fat, protein, calcium than a normal baby would, but they have a very poor ability to take adequate nutrition. And lastly, all systems are immature in a premature baby, especially their pulmonary or lungs, neurologic or brain, and their gastrointestinal systems. If we look at a neonatal intensive care unit, all of those issues require specialized care from the doctors, but also the nurses. And in addition, the pharmaceuticals have to be unique. Premature babies have very immature livers and kidneys, so standard drugs that are used for adults or for older kids don't work well for babies. In addition, laboratory has to be unique. A premature baby has a very small amount of blood, so you can't draw up normal size volumes of blood for lab tests in a preterm baby. In addition, X-ray requirements have to be different for premature babies because they're more sensitive to radiation, and it has lifelong effects on them. Nutrition plans have to be in place for both baby and mother in a NICU. And lastly, your equipment and facilities just has to be there. You have to have a way to warm babies. You have to find a way to support them with continuous positive airway pressure, oxygen blenders, nasal cannulas, sensitive monitors to track their heart rate and their oxygenation, IV pumps, equipment for lactation support of mothers, and consumables that you use in your hospital. These are unique for a NICU. And one of our biggest challenges in Tanzania is that governments and hospitals don't want to invest in the facilities and the equipment for a NICU because they can't use it anywhere else. It's used in the NICU and the NICU only, and that's a hard sale for a hospital. So going back to when we came to Tanzania, I stepped into this single room with 15 babies, and these babies, our babies, weren't doing so well. For example, our very small premature babies rarely survived. Sepsis, which is an overwhelming infection, was almost always recognized too late in the baby. We often had cold babies. We often had babies who were struggling to breathe, and we didn't have a way to support their breathing. We had babies who were not growing well in our NICU. And a baby who's not growing well is a baby whose brain is not developing and their lungs are not maturing. And as a result of all of this, I frankly despaired. And I found myself becoming very avoidant of being in this room because the outcomes were so poor and the needs were just overwhelming. But in late 2014, at the urging of some friends, I decided to take a trip to a hospital in Kenya. Next. And this hospital was called Kijabi Medical Center. And at that hospital in Kenya, a hospital that I had worked at some 15, 16 years prior, I saw that they were doing some things to help their sick and premature babies. They had pumps, they had some incubators. They found some novel ways to help support these babies breathe. And I thought to myself, if they can do it in Kenya, then why not in Tanzania? So we came back to Tanzania and we talked to administration and we decided to put a hole in the wall between two rooms and double the size of our NICU. Next slide. We remodeled Arusha Lutheran Medical Center's NICU, and we opened it in late January of 2015. What a difference this room looked immediately when you stepped into it. We had new equipment present, pumps from Bibron in Germany, and monitors produced by Nonin, which is a company in Plymouth, Minnesota, that does monitoring equipment. We had these special cannulas that we procured from California to help babies breathe. We had this device that you can see in front of you called a urolizer, which was made in Sweden to help detect infections in babies. We had phototherapy lights as well that we acquired. And that seemed great. A new room, new equipment. Oh, and we had new medications for babies as well. Not new in the sense of globally, for these are all medicines that have been used for a long time. But in Tanzania, we were, to our knowledge, the first hospital that was widely using these medicines in their NICU. And we also involved mothers in their care. We started to bring mothers in to help care for the babies, as you can see on the picture to your left. In many hospitals in Africa, if you have a unit, which they call their NICU, loosely termed, mothers may not be allowed to come in to see the babies or to hold the babies because they determine that these babies are too sick. But we started to get our mothers engaged in the care of their baby because I truly believe that there's no better nurse for the baby than the mother herself. And we developed new protocols to take care of babies. And perhaps the thing that we did most of all is we brought in some nurses from Canada and the United States. If you look at this photo, this was our first two nurses who came from Christian nurses. Mary and Louise, who came from Southern California. Actually, Mary and Louise are coming back again to Tanzania this coming week to teach at a conference, but they were our first ones that came to Tanzania, and they really, really helped. Sorry, you can hear my dogs barking in the background. Not much that I can do about that. So with Mary and Louise here to train our nurses, it seemed like things would improve, but in reality, they didn't. Our death rate remained the same. Our outcomes were no better despite all of this. Until, next slide, baby Corrine arrived from an outside hospital. This little girl came in weighing 1.7 pounds or 780 grams. She was 2 weeks old. She came from a hospital that was about 45 minutes away. A volunteer was walking through that hospital, saw this baby gasping, dehydrated, small, obviously premature, and said, let me get this baby to our hospital where maybe there's a chance at her surviving. When Corrine arrived into our NICU, she was septic with an overwhelming bacterial bloodstream infection. Her lungs were failing and her kidneys were failing. She was, for all intents and purposes, a couple hours away from being dead when she arrived. Next. And these nurses who were there with our nurses that were volunteering from the United States looked at Corrine and they said, she's not going to survive. And Mary and Louise said, let's try. Let's do everything we can to actually have, to see if this little sick baby can survive. And so next, we put her on CPAP. We put an IV in her. We warmed her up. We gave her fluids and we gave her strong antibiotics. And she got stronger. And here's where she was strong enough to have her first bath. And you could see that she started to stabilize. Next. Later, she was big enough that you could actually hold her. And I want you to take special notice of how small she is in the hands of one of our visiting female nurses. You can just appreciate that she really is a little thing, less than 2 pounds. Later, next, mother began to be able to hold her, doing what we call kangaroo mother care or skin to skin. Corrine was 3 weeks into our NICU before she was stable enough for her mother to hold her the first time, 5 weeks old by that point in time. And next, here's when she was discharged from our NICU, weighing 5 pounds. And here's when she was 10 months old. And later you can see her at age 3. And today, Corrine is a 7-year-old, beautiful 7-year-old girl running around Arusha, healthy, active, spirited. And this little girl changed our destiny in our NICU. For what she did is that she convinced our nurses that very small and very sick babies are able to survive. Their efforts really do make a difference. And so as a result of that, we grew and we changed our NICU culture. We started to have other successes, like the next photo of Naileji Leji, a little girl born 14 weeks early, weighing only 1.7 pounds, whose name in Kimasai means the one who makes my tears to stop. Nine months of age, a very beautiful little baby. The village threw a party for her when she was eventually discharged from the NICU. And we had other successes that started to accumulate, like Atanguzwe, a baby that was also born under 2 pounds, 14 weeks premature. And here you can see what she looks like today as a 7-year-old little girl in her village. And perhaps one of the most remarkable stories is in the next photo, baby Aichi, whose mother was a doctor. And this little one was born at a government hospital. Mother demanded that she be let go from that hospital, knowing that this baby, only 2 pounds and 15 weeks premature, was not going to survive, and walked with the child into our NICU, skin to skin. And the next video will tell you her story. Fortunata arrived in our NICU holding her baby son, Aichi, skin to skin. He weighed barely 2 pounds or just over 900 grams. He was born 15 weeks premature at 25 weeks gestation.
Alivyozaliwa mimi mwenyewe personally nilikuwa namuogopa. I didn't think he would ever make it, but miracles do happen.
We hurried to warm him and stabilize him, put him on oxygen with continuous positive airway pressure, CPAP, and initially he seemed to do well and respond to our intervention. But over the next day, he suddenly deteriorated, and I remember well walking in the next morning and looking at him, pale, relatively lifeless, struggling to breathe. And I had this sinking feeling that we had a baby that was dying in our NICU.
Every day you go to see the baby, you don't know what you're gonna find. Every walk that you go to the NICU it's torture.
There was one last intervention that we had not yet tried, which was administration of pulmonary surfactant into the baby's lungs. This is a medicine that you put through the endotracheal tube that opens up the lungs and helps them to breathe better. I watched after the procedure as it seemed like his breathing became easier, his color improved. To my great surprise and joy, Fortunata's baby dramatically improved, and we later were able to see him continue to grow and eventually discharge from our NICU.
I'm filled with joy. I'm also called a mother now to this amazing boy that I never thought I would have. A boy that I'd lost hope of ever seeing or ever touching, ever feeding. But today he's alive, he's active, he's loving. He brings a lot of joy to the family. He makes us complete.
So after that, we started to have many firsts in our NICU. We began to see a lot of things being done that by reports were not happening elsewhere in Tanzania. This is just a partial list of the things that we were doing. And as we grew, we made mistakes. We figured things out. Some stuff we actually had not heard of anyone doing before. Others we were borrowing and adapting from NICUs in the States and other countries. But it was an exciting period of time for the first years as we were breaking new ground and we were seeing these small babies survive that never before used to. You remember I told you that the extremely low birth weight babies were only surviving about 1 out of every 5 or 20%. But that number started to rise as more and more babies who were sick and small lived. Our nurses developed this deeply held belief that it was possible and that they could actually have these babies survive, that their efforts and their actions made a difference. It was not up to fate or the will of God whether this child lived or died. And today I'm very proud to announce that our survival rate for the smallest of these babies is about 80%, up from 20%. How does that compare to most hospitals in East Africa? Most hospitals have about a 5% survival rate for extremely premature babies. And this is an example of one of the mothers, Sabina, on your left. She had lost 5 consecutive babies in a row to prematurity. Her husband worked in the Army. He took her from hospital to hospital with every pregnancy, hoping that the next one would survive. And in every hospital, she went into preterm labor. They whisked the baby away, and they came back hours or a day later and said, "I'm sorry, your baby has died." On the 6th delivery, she delivered in our NICU, and this is her daughter, who's called God Blessing. This was probably one of her smallest babies, born at about 1 kilo or 2.2 pounds, 3 months premature. This little girl sailed through our NICU, and the father looked at me and he said, "If I had known what was possible, I would have had every baby born in your hospital. This little one will become my best friend in life." He was so touched by it. But around that time, we learned a very important message, which was, it was not just about the baby. We were doing this to restore the mother's dignity, to preserve her marriage, to lift off of her this sense that she was cursed. Because women who lose pregnancies, especially multiple pregnancies, become gossiped about, whispered about. They tell us that they're cursed. Their husbands leave them for other wives. They become socially outcast. And so it's more than just the baby. We are trying to restore value and dignity to these mothers who otherwise would feel quite destitute. That's why Aichi's mother, Fortunate, said to me, "He makes me complete." A concept that we don't understand in the West, but in Africa, the idea that you have a child, and because you have a child, you are now complete. Your lineage is being continued. That circle of life is coming back around. That's a concept that they deeply believe in. And so when we send a baby home with a mother, these mothers will say to us, "You have given me love." And what they mean by that is, now I have an opportunity to experience love in a way that I didn't before. Thank you. So as we go forward, in 2016, we started our own initiative called Every Breath Counts. We began to teach neonatology across the country to government hospitals and mission hospitals. And if you look at 2021, that was a banner year for us. We had 340 babies, and over 50% of these admissions were for prematurity. So the other half are term babies. Our overall survival rate was 92%, and our preemie survival rate was 90%. We had over 25 area hospitals now sending us their babies. And we never turned away, since our history, we've never turned away a baby due to money issues. Because I don't believe that a baby's life or death should depend on whether the parents have the money or are willing to pay for their baby. We use only appropriate technologies. For now, we've never used a ventilator. We focus on improving feeding and CPAP protocols, which I'll get to in a bit. And we train at every opportunity possible. And in 2022, we're still growing. Our census year to date is up 11% over last year. In addition, last year we produced a manual for neonatal care called Every Breath Counts. It's about 400 pages, and we have distributed this book as a guideline for how to take care of sick babies to about 80 or 90 hospitals throughout East Africa. Last year, we held a conference called Tiny Feet, Big Steps in Arusha, where we had over 160 doctors and nurses coming from across Tanzania. And this little guy on the right, Frank, well, he was in our NICU for 112 days. He got down to as little as 1.5 pounds. He holds the record for the longest NICU baby we've ever had, and he was a star hit at the conference last year. We're going to hold the conference again starting next week. And so far, we have 9 countries and nearly 250 doctors and nurses from 70 plus hospitals signed up to come to this conference. And by the way, we have a very large team of people flying out from Wisconsin and Minnesota to help teach at it. So if I step back and I look at our NICU, I come down to really 3 steps that changed our NICU and would change any hospital's NICU. Number 1 is temperature, it's breathing, and thirdly, it's nutrition. These 3 things make the biggest difference in outcomes. If I go to the next slide, the first thing you have to do is keep the baby warm. You have to maintain their temperature, or what we call thermal regulation. That's a priority for all infants. And it's very well documented that hypothermia increases significantly the morbidity and mortality, especially in preterm babies who can get cold in just a matter of minutes. Hypothermia is preventable, but it's something that I see every hospital struggling with, especially during resuscitation of a baby after birth. These babies are wet, they're in a cold delivery room, and they become rapidly cold. There are multiple mechanisms of heat loss that can happen with a baby. They can lose through conduction, their warmth, through evaporative losses as they're not dried properly. Convection and radiation of heat also contribute to heat loss. And if you look at temperature and oxygen consumption of a baby, when babies are overheated, they increase their oxygen consumption. That corresponds to their metabolic rate increasing. When babies start to get cold, they will also increase their oxygen consumption and their metabolism will increase. But as body temperature drops, babies suddenly stop consuming oxygen, corresponding with they slow their breathing down. And somewhere around 30 to 31 degrees is where we start to see babies who at this temperature don't survive. That's where death is happening. And that's one of our biggest problems, because many babies who come into our NICU from government and outside hospitals, by the time they reach us, they're already at that place of 30, 31 degrees Celsius. These are babies we can't save because they were allowed to get cold after delivery or during transport to us. There are simple interventions that we try to teach hospitals to do, such as the use of a plastic bag. If you can put a preterm baby in a plastic bag, you actually slow down the rate of heat loss, you increase the humidity in the bag, and they actually lose less body weight from evaporative losses. A lot of people want an incubator as a way to have a baby be saved. This is one of the very first incubators that was on record. It was in 1932 at one of the world fairs that they actually demonstrated it. You can see that there are 3 little babies in this incubator. And incubators are a problem for much of sub-Saharan Africa. If you look at incubators today, it's really hard for a hospital to fix it. Some few years ago, I did an interview with some media people about why it's so hard for a hospital in Tanzania to fix broken incubators. There are studies that seem to indicate that roughly 70% of incubators in low and middle income countries are not working properly. Electrical surges, lack of spare parts, missing components, lack of hospital bioengineers, all of those contribute to incubators that aren't working well. And not only that, but babies that are put in incubators oftentimes have higher infection rates and higher death rates because they're neglected and ignored in the incubator. So prevention is best. And this is, again, a low-tech solution. You can see these mothers all doing kangaroo mother care with their baby. If you can get a baby against the mother's skin and bundle that baby, they're skin to skin against mom, they're bundled, they have a hat on, the mother's body heat will thermoregulate most premature babies and definitely help. This is what we try to get hospitals to do when they send us the baby. Put the baby against somebody's skin, skin to skin, and transport the baby in that mechanism. For we must remember that technology, such as an incubator, must be a tool for the mother and the baby, and it must not stand between mother and baby. So much of what is done in a NICU actually keeps the mother away from her baby, and we should be creating systems of interventions that actually bring mothers in and help them be engaged and bond to their baby. So if temperature is the first step in saving babies' lives, second is breathing. You have to help the baby breathe, such as this photo of Naileji, who's on bubble CPAP. In the next video, I want to show you just what it looks like when a baby is struggling to breathe. So in this, you can see the baby is pulling hard as she breathes. We'll go back a bit, Doug. She's pulling hard as she breathes. Her intercostal muscles are working. She's probably grunting. Her head is moving. Her abdomen and her diaphragm are working overtime. And this is because her lungs are stiff. They're not compliant. Her chest wall is weak, and her muscle strength is not great. And this is a recipe for disaster in a premature baby. So how do we keep the lungs open? Through a medicine called surfactant. You can go to the next slide, Doug. And continuous positive airway pressure. CPAP. You may have known somebody who's on BiPAP, who has obstructive sleep apnea. Babies, we use something very similar to that. We use what we call CPAP, and it actually helps keeps the upper and lower airways open, keeps them from collapsing. It improves the area of gas exchange, and it decreases the work of breathing. And in the next slide, you can actually see how we set that up in our NICU. It's really quite simple. You have oxygen flowing into one circuit of the inspiratory tubing. And then from the expiratory part of the tubing, you have it connected to a water bottle that can control the depth of underneath the water, and that reflects in how much pressure is in the circuit. And then it gets relocated into the baby's nose and helps them with breathing. CPAP has been used for a long time around the world. We use it with incredible success, and it's low tech. Probably half of all of our babies end up on it. It absolutely is one of the main reasons why our babies survive in our hospital. In addition, coming back to the next slide, skin to skin, well, that also helps reduce respiratory distress. So even babies who are on bubble CPAP, we put them up against the mother, and just her presence helps the lungs mature more quickly. So temperature regulation is one. Helping the baby breathe is the second, support the baby's lungs. And thirdly, you have to do nutrition well. You have to know how to feed the baby, both the correct volumes at the proper intervals and with fortification. And in the next picture, you can actually see we created a guideline for how to feed babies based on their gestational age. And we rapidly increase their volume of feedings. Even our smallest babies, by the time they're 7 days old, we have them on full enteral feeds. We advance our feeds. We fortify them with extra formula mixed with the breast milk to boost the calories, the protein, and the calcium. And rapid feeding advancement of our premature babies contributes to their nutrition, and their nutrition helps their lungs to mature, and it keeps their brain growing. It helps their immunity. It makes a difference. One of the other things that we do is introduce cup feedings to baby. So we try to avoid bottles. We go from feeding a baby through a nasogastric tube, which costs all of $1 to buy the nasogastric tube, still hard to find in most hospitals. Then we use cup feeding. Then the baby eventually old enough, strong enough, coordinated enough to do breastfeeding. One of the things that I'm very impressed with in Tanzania is that our babies are good at surviving. This is a truism of neonatology, that African babies survive at much higher rates given any level of gestation compared to a Caucasian baby. They are remarkably strong babies, and we can do stuff with a low-tech environment that would never work in the United States for reasons that these babies are good at surviving. And that's just a fact. Nurses and doctors who come out and work in our unit are always amazed at our outcomes relative to their experience working in the United States. But I ask the question, if they're good at surviving, what about thriving? And that is where I believe we have a long ways to go. This is why we teach a lot of our doctors and nurses how to help feed and improve nutrition. So in conclusion, I just want to go back and look at our journey. And these are the steps that we had to take. We had to get good at temperature. We had to help babies thermoregulate. We had to help them breathe, and we had to support their nutrition. And we developed protocols around that we have been sharing with hospitals across East Africa. But I come back to the concept of nursing, because I really do believe that nurses are the most important part of any NICU. Hospitals rise and they sink based on the level of nursing care and ability. And unfortunately, in Tanzania, most nurses are not trained very well. They don't have a lot of role models of what a good nurse should do and how they should work. If a nurse works very hard and outperforms other nurses in her unit, she's quickly shamed or reduced down to a level of performance that's commensurate with everyone else. And so it's really quite a challenge to get our nurses to elevate their game. But we've managed to do that. And we've managed to do it because our nurses are eminently teachable. They really do care about the babies. And we have to create a new culture where nurses can be elevated and respected and engaged as part of the team. The other thing we have to do is train our doctors. And training doctors is a journey of accompaniment, meaning that I don't shame them, I don't scold them, I walk beside them, and we engage our doctors in a way that is very relational. I've found that the Tanzanian doctors I work with are exceptionally bright, extremely hardworking, very motivated. And if I can change the NICU culture where the nurses are more proactive and the doctors engage the nurses in a respectful way, not a condescending way, then we've changed the culture and we can have babies live that wouldn't otherwise. But it also takes more than equipment and classes. It starts and it ends with the medical culture and understanding and changing the belief system of the hospital. And this is my one bone of contention to pick with a lot of international aid groups and NGOs, and even doctors groups that come out. They think that if they just bring in equipment or they come and they teach a single class, somehow they will change healthcare outcomes. And I look at those equipment and I go, it doesn't change your outcome. not unless you change the culture of doctors and nurses. I elevate both of them, put them on the same level, get them to work together, get them to talk to the families, and get them to believe that their efforts really are rewarded and that neonatology is anticipatory and interventionary, not passive and reactive. And when I look back on my journey in Tanzania, I have to come back to nothing that I've ever done in life as a physician can match the joy of experiencing something like this, which we are now experiencing hundreds of times every year in our unit. I'll end with one last video for you, and it's a story of Cecilia. It's a little Maasai girl. Often Maasai girls have lesser value in that culture, who was born in an area by Ngorongoro Crater. A very astute doctor who I know quite well saw this premature baby and said, let's get the baby to Arusha Lutheran Medical Center. The grandparents opposed the transfer of the baby, didn't think that this baby would live or was worth surviving. But this is a story of what actually happened for baby Cecilia. Our philosophy here in our NICU is that every baby deserves the opportunity to go home with a mother, and it should not depend on the family's educational status or ability to pay. This is our newest admission to our NICU. It's baby of Cecilia. She was born 11 weeks premature, weighing just over 2.5 pounds or 1.2 kilograms. By the time that she arrived to us, she was already 24 hours old. Her body was cold. She was struggling to breathe. Her color was poor. Our initial blood gases showed a baby that was both in respiratory failure and showing signs of severe infection. I looked at this little girl and I had my doubts as to whether or not she was actually going to survive through the night. But our team placed a central umbilical venous catheter. They intubated her and gave her pulmonary surfactant. They gave her fluids. They started her on the right antibiotic, and they put her on bubbled CPAP to support her breathing. She's now under phototherapy lights. By this morning, she is dramatically improved. Her skin color, her breathing, her activity is really like night and day compared to her condition on arrival. This is a baby girl that was born to a family that has no ability to pay for the NICU expense. We decided that this baby would be under the NICU fund, fully covered through generous donations that come from individuals like yourself.
Thank you so much. I think we are unfortunately at the close of our time. I know there are more questions and thoughts and comments that all of us would love to share. And I want to respect the promise we made to you, Steve, about your schedule too. And so I'm afraid we're going to have to close here. I do want to say, Steve, that I look forward to a future when this training that you are able to do, and not just you, but the whole team there, launches more internationally and across Tanzania as well. You're doing it right now, but I think the venue for training has only just begun, has it not? And we pray that many can find new protocols and a new culture in NICUs that really bring life. Praise God. Thank you for this. Can I give you one last little comment from all of us? Would you give him a round of applause because he can't see our faces?